a favorite topic for you, Antonio. So what about the value of maintenance and or continuous therapy? And for me, I lump them together because conceptually I view them post-transplant or in a non-transplant setting. The concept is really much the same for me. So, agree. Obviously, we don't need to show a lot of data here. I think that we're familiar with the data that's been presented. We have lenalidomide maintenance. We have other data using bortezomib combinations. And basically, we have evidence of both PFS and survival benefit with a continuous approach. And so the question is, how do we take this information in terms of making a recommendation in individual types of patients for continuous therapy versus not, or something in between, a fixed amount which might be 2 years or something like that. And so we have a short fixed duration, maybe 18 months, a maintenance with a fixed duration, or to progression. So maybe start with Joe.
Joe,
what do you think?
The right person to start with. He's 85% in agreement with me, so that's.
Hey, look, I absolutely agree. I think the field is moving more towards continuous therapy. So the way I'm generally approaching it is saying, there's absolutely yes for a certain group of people. There's generally less for a certain group of people, and there's not likely in a certain group of people. So the absolutely yes, high-risk patients, patients who still have a lot of disease, although I must say it might not all be about maintenance and continuous. In light of what Ola was just saying and we were saying together, more consolidation may be the opportunity. If we're trying to get down to MRD negativity, maybe instead of saying, and maybe this is one of the reasons why the French trial is different than the American study, where they gave induction therapy, transplant, and then everybody got 2 months of consolidation. So in general, you might be able to say to some patients, would you rather have 2 months or continuous therapy? They might wish for 2 months. So I'm absolutely in favor of either at least intensification or consolidation and long-term therapy for the high risk. For the very standard risk patients, you know, it's still hard to deny that 15-ish% of patients, I wish we could predict them all, but we can predict a number of them, like the patient I saw last week in clinic, who's 4.5 years after transplant, not on any therapy, living a fantastic quality of life. So I'm not saying we always do it. And then that middle group is very analogous to what Antonio and Ola said earlier. It's not continuous or bust. If, with a big capital I, there are toxicities, then it's reasonable to consider either dose reducing or even stopping. So, you know, to put a blanket therapy and say absolutely everybody needs continuous therapy until the very bitter end is a bit tough. That high-risk group that are likely to bounce back quicker, we should. The majority in the middle, I think we should consider it, especially if they're not very deep in response. But there may still be a small subset in whom we just watch really carefully, who prefer not to go on further therapy, who've experienced toxicities, where we can say, okay, let's just watch you closely and potentially intervene. Because there are still some toxicities with maintenance therapy, second primary malignancies, neutropenia, not dramatic with the newer drugs, which is great, but still present. So I guess I'm inching a little bit closer to Antonio, but
so how close is he, Antonio?
We are already 85, you see, it's coming. We will like approach 98 next year.
All right.
Just a matter of time. I will make this comment. The first, once again, there are clear evidence of the benefit of continuous treatment, major improvement in remission duration. Majority of studies are also showing survival advantage. So generally speaking, I think more and more is becoming a consensus the use of continuous therapy. We do not know if we need until progression or only 2 years or a fixed number of a fixed period. This is certainly an open question. I completely agree that a continuous treatment makes sense provided there are no toxicity. I'm stressing the concept, no toxicity. To make a simple example, you know, doesn't make sense to have continuous treatment and end up the continuous treatment with 10,000 platelet and being unable to give any salvage therapy. So it's critical that continuous therapy makes sense, provided there are not minima, there are no toxicity. But I would like to do a final comment. I was very impressed by the presentation of Saji Kumar on Ixaxomib and the continuous therapy. And beside an intense inductions, basically during maintenance, they were able to show that 50% of patients did improve their response. So once again, this is another major evidence of the need of a continuous therapy, but also that the profound cytoreduction is a late event, is not an early event.
Right. I think we're maybe relearning the fact that the biology of myeloma is of a slow-growing disease, so that it grows slowly and goes away slowly. You need to keep working at it. So, continuous?
Yeah, I think my answer to this question is yes. I think the way to go, I think we have the same discussion in these different kind of aspects here. Have a non-intense, effective combination with the best drugs up front, and then have more low dose therapy for extended dosing to prevent the disease from coming back. And I think if we can bring patients into MOD status, the next generation of studies that needs to be done is to test what happens if you stop versus if you continue in patients who have maintained an MOD status for a fixed period of time. And we obviously don't know how long that would be, but I could envision we have studies where we could in the future say you have been MOD negative for 3 or 5 years. Maybe you could go on a new study, and the study will monitor your MOD status on that study, and you could either go on, off, or you could stay on, and then you can follow. That will be the only way to answer the question in a rational fashion. Until that's done, it remains unknown.
Right. So I think we certainly do need to do that, and I think I agree with you, Antonio, that with Ixaxomib, where you have a very well-tolerated ongoing regimen, it makes it a lot easier to consider trials like that. You could give it for different length of time and then follow off treatment versus on treatment.